Our first presenter today is Ms. Rebecca Trott, LCSWC. Ms. Trott is the program manager of the Road to Recovery program at the Anne Arundel County Department of Health. She oversees the program's 3 opioid treatment programs, 2 located in the community and 1 located in the Ordnance Road Correctional Center. She also manages the department's Well-Mobile that provides mobile access to low barrier buprenorphine, peer support services, and harm reduction resources. She's a licensed clinical social worker working in the behavioral health field since 2015. And our second speaker is Captain Steve Wallace from the Kent County Department of Corrections. Steve is the administrative captain and currently also the program supervisor for the Kent County Detention Center, where he oversees all programs such as pretrial release, home detention, their MAT program, the GED program, addictions counseling, as well as other services. He's been a correctional officer for over 28 years, and throughout his career, he's held many positions. Captain Wallace is highly dedicated to his agency and really enjoys helping other people become successful, as you'll hear.
All right. Good morning. Thank you so much, Anne. And good morning, everyone. Again, my name is Rebecca Trott, and I'm the program manager for the Road to Recovery program. And I'm going to be talking a little bit about our opioid treatment program located within one of the county's correctional centers, the Ordnance Road Correctional Center. So the Road to Recovery program is a program that sits under the Anne Arundel County Department of Health. So I'll start there in that we are a county program. We're a Department of Health run program, and we're working with another county facility. So I say all that to say that we are a unique setup. We all, before we even started the program, had some assistance in being in the same system as far as communication goes. And I think that really played into the success of this program. The Road to Recovery program currently has 2 community opioid treatment programs, and 1 within the Ordnance Road Correctional Center, and then a mobile low threshold buprenorphine induction program that's out in the community. The Anne Arundel County Detention Facilities has 2 centers. It's the Ordnance Road Correctional Center, which is a minimum security facility with sentences of 18 months or less. And then the Jennifer Road Detention Center, which is a maximum security facility in which all of booking occurs, which is really significant for us as far as treatment is concerned. I'll talk a little bit about that later. So I thought I'd take us back a little bit to kind of the beginnings of this program, the opioid treatment program within the Ordnance Road Correctional Center, which I'll refer to as RTR moving forward for a sense of time. The conversation started happening back in 2010. At that time, when the Department of Health had some presence within the correctional centers. We were really providing substance use disorder assessments and referral information at that time. We were limited to that. We had really a really low amount of individuals that were accessing treatment post-release. Looking at the numbers at 2010, there was only around 1 out of the 450 inmates that we assessed that actually accessed treatment post-release. And really at that time, one of the reasons for the conversation starting to happen about wanting to implement more treatment in the correctional centers was to address this barrier of accessing of connection to treatment post-release. And then we knew, looking at rates at that time, that there was just such a significantly high rate of overdose within the first week of release. Data at that time really showed us that around 85% of individuals that were in treatment during incarceration so 85% were more likely to enter treatment post-release compared to 15% that did not receive treatment while incarcerated. And then looking 6 months down the road, 50% of those were still engaged in treatment compared to the 5% of those that did not receive treatment during incarceration. So that was kind of the pushing off point that led us to start looking at what we wanted to do as far as integrating treatment within the correctional center. Later that year, we started discussing ways that we could implement treatment, and the Department of Health already had an established opioid treatment program, so that felt like the best place to start. So collaboration began with the Anne Arundel County Department of Health and Anne Arundel County Detention Facilities. And as I noted, we're all under the same big house at the end of the day. And I think that plays very significantly into why we communicate so well with one another. We speak the same language, have the same overarching kind of barriers and help. And we all had kind of the same goal in mind. And then certainly a huge piece of this was integrating already established regulations as far as OTPs were concerned into this program. We live by these standards in opioid treatment programs. And they're really, really significant, not only in the community, but the same rules are at play in a correctional setting. So we have federal and state guidelines looking at the PEP 15 and COMAR regulations that play heavily into program guidelines, what required services we have to provide, caseload, medication privileges, admission, all that comes into play. And even though we were in a correctional center and looking at implementing this program in that system, everything remained the same, and we had to comply by those things. Which kind of leads me to the next piece, which is our accrediting body. Being an opioid treatment program in the state of Maryland, we're required to be accredited, and we are accredited by CARF, the Commission of Accreditation of Rehabilitation Facilities. This is a accreditation that happens every 3 years, where they come out, a very intensive survey. And we had to assure that we were meeting all of those standards as well, even though we were in the facility. And there were certain things that we could say we couldn't do because we were in a correctional center, but we had to find ways to work around it and make sure that we were complying with them. And then the next two biggest pieces is the DEA and being registered with the Office of Controlled Substances Administration. The DEA is a huge focus for us, and I think is the number one focus when going to implement a program. They are the starting force. Are we meeting what they need? Their focus is to assure that our medication is safely stored, that we're accounting for inventory, assuring that there is proper diversion control, and then that's maintained on a regular basis. And I'll talk a little bit more about what that looks like as far as setting up the room, but we have to continuously assure that we're maintaining those standards. And then in all of that from the OTP world, we also have to make sure that we're complying with the standards for the Maryland Commission on Correctional Standards and any accrediting bodies that the correctional center might have. Next slide. We talked about the standards, kind of the starting piece. Next step was design. And the first and most important thing is, where are we putting medication? This is always the first step in starting an OT. Well, one of the first steps is, what is this going to look like? I was talking to one of the captains yesterday, and he jokingly said this, but it's not so funny, is that the medication room within the correctional center is the most secure room in that correctional center. It has its own alarm system. Only our staff can access that room. It is in an interior space, which is huge. It's not accessible by any outdoor walls. They're looking at the ceiling, making sure no one can climb in through any ceiling panels. The medication safe is bolted to the ground because it's less than 750 pounds. Our dispensing window has a turnstile table, so that assures that patients can only access the medication and nothing else. And it's checked, and we do alarm checks on it on a regular basis. Only certain staff, I noted, can access it. So that was number one, setting up a space. It's a very small room at the end of a hallway, but it is the most significant step for us. And I think the biggest piece is, where is that going to fit? We're setting up a room in an already established correctional center that needed to carve out space for us, which moves me to the next point, is what other needs do we need to have? So our program is set up to admit up to 100 patients, which means we had to have 2 counselors, and counseling runs the show as far as admissions go. We can only have our caseload is going to be based on that. So we have 2 counseling offices that were set aside. as well as an office that was set aside for medical intakes and admissions with our medical director. Part of that was set up in an MOU that we have with the correctional center to assure that really we had clear and established requests from both ends as far as what we needed. And then the next two things were workflow and integration. So we were interrupting the normal flow of a correctional center that had a very clear and strict structure, right? So where were we going to fit into there? And so implementing a really strict schedule that we were going to follow as far as medicating, along with being extremely flexible and accommodating, was huge in this. We look at ourselves as guests within that correctional center. We are there to provide a service, but they are running the show. So when there is a lockdown, when inmates can't come off the unit, we are adjusting, waiting, and being patient, and understanding that we can't change safety, and that's going to always be paramount and come first. And then we also had to consider things like guard duties, shift changes, what it looked like to transport patients. All of our patients on methadone come down at the same time. And what does it look like as far as how they medicate to assure that we're still protecting the privacy of those patients as well when they're receiving their medication, and then other service implications that might come into play, like lockdowns. During COVID was a huge shift for us. There was countless lockdowns, countless units on, that we just couldn't access. So we had to change how we did things, go on the unit to medicate on times, and just be patient with the flow of things. When we first got in there, after we talked about what the program was going to look like, we talked about what the layout was going to look like, schedules, all of that was educating staff. The Department of Health already had an opioid treatment program. We had staff that knew what we were doing, believed in what we were doing, but we were going into a setting, to kind of echo last presentation, where staff didn't know and didn't have a full understanding, and were coming in with misconceptions and a lot of stigma around treatment. And I think the thing at that time that was really helpful, aside from really sitting down, debunking myths, trying to reduce some stigma around substance use, was just being there. Having a open door to provide space for questions, concerns, and still to this day, when things come out or there's questions, providing a space where officers feel that they can be heard and listened to, where we're there to provide education in a way that is a way to support the role that they have, so that we can work together. And really, we've had tremendous support from Anne Arundel County detention facilities throughout this entire process, and they continue to be a major support for us. So in 2012, the Road to Recovery Clinic opened. At that time, we started with just continuing medication. So individuals that were already established within community OTPs upon incarceration, we were continuing their treatment when we first started. And then within the year began to work towards admissions for individuals that were not currently on medication. In 2012, we were only doing methadone. Starting this year, we are providing all three forms of medication for opioid use disorders. And our goal for the program initially, and our continued goal, is to assure that there is a continuity of care, not only while they're incarcerated, but when they move to the community as well. So currently, our program provides the following services. So we have counseling. Every patient that comes in is assigned a counselor that they meet with on a regular basis. They get ongoing medical assessment, an initial medical assessment, ongoing appointments, and we do random urinalysis testing. As I noted, the biggest goal for us is planning for release, continuity of care, and planning for that connection once they leave. It's one of the first questions that we're asking when they get in is, where do you want to go when you leave? And making sure that the patient knows that, knows where they're going, and also knows that they can always come back to the Department of Health's community programs if for some reason they can't get to the clinic that they want to return to. Within the correctional center, the Department of Health also offers peer support services, as well as we provide naloxone kits to inmates at release and have access to other Anne Arundel County Department of Health programs within the facility. I want to talk just a little bit about what the process looks like for an inmate coming in currently. There's two pathways to treatment. Pathway one is you're already on an established treatment program within the community. And what that looks like is the individual notifies staff at booking that they're currently in a treatment program. And immediately that staff member has them sign a release of information for the Road to Recovery program and the individual's home clinic. And then we begin the process of coordinating guest dosing. I'll show you a little later, but we have a large amount of guest dosers that we service. It's kind of overtaken things compared to our admissions at this point. And we can have that process, an inmate can be booked today and start medicating the next day. That's our goal, is to get them medicated as soon as possible. And then they are automatically placed on an intake list so that once they are moved to the Ordnance Road Correctional Center, we are starting the process of admitting them. Right now, they're still, once they're booked within the Jennifer Road Detention Center, which is their maximum security facility, they remain there for a minimum of 2 weeks before they're transferred out, depending on what their plan is for them next. For individuals that are interested in getting on treatment, getting onto methadone or Vivitrol or buprenorphine at this point, they can request to be screened. All of the housing units have a kiosk on unit that they can request to be seen. So they'll put in a request. Our counselor will go down and do what we call a pre-screen on them, which is an initial assessment to get some information about their treatment, where they're going, their history. And then that case is reviewed at a treatment review meeting on a weekly basis for approval by our medical director. There are a few reasons why someone might not be approved, or where we might want to talk with them before approval. I think our biggest one right now is if they might be going to DOC. We're very hesitant to start them on medication and want to have that conversation because of the likelihood that they're going to need to be tapered off, or that they're not going to get access to that medication once they're transferred. And then if they're approved, they're admitted and we begin medicating. Already talked about this a little bit, but release planning is huge for us. We are already planning for the clinic the individual is going to return to. Our community clinics in Glen Burnie and Annapolis are always available. If that person, decides that they want to come to our program, or for whatever reason can't get to their home clinic. And then we don't always know when someone's getting released. More often than not, we don't know when someone's getting released. So the day after we're released, our nursing staff is immediately confirming the last dose with whichever clinic the patient identified that they'd like to go to, and then with our community clinics. So wherever they show up, we're ready to serve them. And the last 3 fiscal years, which if you can go down to the next slide, we'll talk a little bit about, we've had a 100% treatment connection. So that means every inmate that we've admitted has been connected to a clinic post-release and has medicated there. And that's huge for us. That's our goal in this, is to make sure that we are serving them while they're incarcerated and getting them connected to a program at release. Since the implementation of this program, we've admitted over 1,900 inmates. And looking at the last 3 fiscal years, we've had a big jump in guest dosing. We had fiscal year 2021 was definitely our slowest year. Incarcerations were down. There just wasn't a lot of movement. Our admissions have been significantly down, but we've had a lot of guest dosing. And a lot of that is because we're servicing the Jennifer Road Detention Center by delivering medication down there at this time. So the inmate will be at Jennifer Road, but guest dosing with the Road to Recovery program. And we are delivering medication until the time in which they can come to the Ordnance Road Detention Center. But like I said, all our admissions have been down, but guest dosing has been up. So moving forward for us, we have exciting new things on the horizon in light of the House bill and expansion. We are expanding treatment to the Jennifer Road Detention Center through the implementation of a mobile narcotic treatment program. So this vehicle will be based out of our community clinic in Annapolis, which will be its brick and mortar. And we will start being able to provide services to the Jennifer Road Detention Center and start providing admissions most significantly. So anybody that's not currently on a program, we can begin offering treatment to. Sorry, that was the slide that I was just talking about. Sorry, I didn't realize it expanded. So this is our van that should be delivered to us shortly that we're excited about expanding these services to.
Wonderful. Thank you so much, Rebecca. We'll go ahead and we'll pass it on to Captain Wallace, and let's take questions at the end. Captain Wallace, just make sure you're unmuted. Perfect.
Good morning. As she stated, I'm Captain Steve Wallace from the Kent County Detention Center. Been doing corrections for about 28 years in a variety of capacities. This morning, I'd like to talk about the challenges that we face currently as a facility as far as methadone. Currently, our facility does not have a methadone program. We do have a MAT program that we started about 9 months ago, and it's working really well thus far with the partnership with Friends and University of Maryland and Recovery in Motion and all the other fine people that's reached out to us and gave us support, which we certainly thank, because without them, none of this would be possible. And then we, as Dr. Weintraub said, we reached out to Mountain Manor, reached out to 16 different treatment facilities for the addiction side. And luckily, Mountain Manor provide telehealth treatment for the ones that are on the MAT program, because we're currently looking for a MAT manager, if anybody knows anybody that's available for the program. Right now, we're doing it ourselves as far as keeping all the data and the stats. Back to where we were at with the methadone. When we have an offender that comes in or is pregnant female that is on the methadone program, our facility must do the following. We transfer the offender to another facility that has a methadone program, provided they have space. Once we transfer the individual to other facilities, we have to still do all the transports, whether it be court, medical, which requires oftentimes 2 officers due to the distance of the other facilities, because most of the facilities that have a methadone program are quite far away from our facility. We have established a relationship with the community methadone provider, so it's not required to have a special licensing for methadone dispensing at our facility. And what we do is, if an offender stays with us, we must transport a person to a methadone clinic, which either is in Easton or Cecil County. At least for the first time, they have to be in person, and they will actually sit down with them and go over the program, issue the first dose, sit there for about a half hour to make sure they don't have any type of reaction. And this process usually ties up staff for several hours, which creates a hardship for the facility. Therefore, we have established a relationship with the clinics where they will give us 2 weeks supply of methadone, provided we have a nurse, correctional officer, and a lockbox with us on the day that we go and pick the methadone up. Then every 30 days, we must transport the offender back to the methadone clinic for an in-person assessment to see how it's going, if they need to increase, decrease, or whatever the case may be. Our concerns are transporting and storing the controlled dangerous substance, and there is a considerable liability in storing a highly regulated controlled substance such as methadone. In our facility, we're not accustomed to handling methadone. Nurses were concerned about the liability issues in their licensing if a dose was misappropriated. This process, creates a lot of concern, hardship for our facility, our patient, staff, and our nurse for an already understaffed environment. I don't know if anybody's aware of it. In the last 9 months, we went through 5 nurses for a variety of reasons, and you can only imagine how that disrupts the facility's day-to-day operation. But by reaching out to other facilities, as Dr. Weintraub mentioned, Miss Angel at Allegheny County is a godsend because she runs the program up there. She does a phenomenal job. And it's nice when you can reach out to other resources and without hesitation, and they're ready to help you. And that's really comforting. So the only thing I would like to add is if any agency has experienced different types of patient diversion, please reach out to each other so we can look for that type of diversion. It's very instrumental for all of us to try to work together, and we want them to get the medicine, but diversion we try to control. We know that it's going to happen, but if someone finds something new that they're doing, please by all means reach out to us via email so we're all on the same page. The methadone has been a extremely hard challenge for our facility as far as financially and just dealing with it. And we probably had 6 or 8 females in the last year that were pregnant, were currently on methadone. And we had to, make the trip because other facilities are either full or, understaffed. It's been a struggle. It's been a struggle.
There was a question about the average census. What's your typical census, Captain Wallace?
Well, pre-COVID, it was like 60, 70. Now it's probably 35 or 40.
Okay.
And then we drug test. I don't know if other facilities do, but we drug test everybody as soon as they come in, especially if to see if they have fentanyl in so we can take the proper protocols. And we would probably say 8 out of 10 have 4 or more substances on board at any given time. So it is an epidemic, and it don't, it could be doctors, lawyers. We get a variety of people in here. So it's a wide spectrum of people that we're seeing that's dealing with an addiction.
Mm-hmm.
So it is a serious topic, and a lot more money and time needs to be spent on this. I believe, like Dr. Weintraub said, overdoses, I believe, are considerably reduced if he or she's on a program prior to being discharged from the facility.
Both the capacity to internally treat and the partnership with the health department and the programs or the ability to develop the programs is widely different in these 2 counties. And I'm sure that some of the challenges that they're facing out in Kent County in terms of needing to transport inmates to local programs and the staff time and the cost and everything else associated with that is not unique to them. I don't know if other counties have other approaches to delivering methadone than the 2 that we heard, or have questions for our presenters about that process. I have a question for both of our presenters, and that sort of addresses the broader availability of methadone treatment in the county. And Rebecca, you said like the number of people that you're medicating and continuing on methadone has really surpassed the number of people that you're initiating in new methadone. But there are a lot of methadone treatment programs available in your area, so that completely makes sense. Whereas Captain Wallace, right now you're just currently limiting your treatment to pregnant women and getting them the medication that they need. But there aren't, as you said, just to get them to an OTP, it's a long drive for your custody staff as well to get them to the program. And I wonder if you could speak to how those broader community factors are influencing the way you're thinking about the importance or the salience of methadone specifically, as opposed to the other medications for opioid use disorder.
As far as, I think there's research being done where if someone comes in all methadone, I can't really speak on, I think Dr. Weintraub, that they can be switched over to Subutex. So I don't know how much study is being done about that, but I think that would be a great alternative, providing there's enough research done that, it's safe. Main thing is making sure everybody's safe, of course. But like you mentioned, the struggles that we have guys that come in on methadone as well that were in a program. And it is a burden, not only for staff, but to nurse and just financially and from a security aspect. Anytime you leave the facility with somebody, it's a security concern, of course. But it is a struggle, and if they could go from methadone to Subutex, I think that would be a great thing for everybody involved, providing it safe as far as financially and having to transfer somebody to another facility and et cetera. But I'm not sure if enough studies been done on that or not. But we are looking into that, and if it is safe, I think that would be a great alternative.
Thank you for sharing that. Yeah, that's a really interesting point. It looks like Larry Stewart has his hand raised. Larry, you want to unmute?
Sure. Good morning, everybody. It's been a pleasure listening to everybody this morning because I'm hearing so many folks that have had a similar path. You guys are the trailblazers getting things rolling, and we've done so many of our startup things so similarly. Captain Wallace, when we first started our program, I manage an outpatient OUD treatment program in the community, and we've partnered with the jail to begin bringing MAT to the jail. But when we started this program, the jail was having the participants transported, with multiple, I think they use sheriffs to do the transportation, bring them down to our clinic to see the doctor, to et cetera and so forth. And I mean, just logistically, it was a nightmare. And from, the custody and security perspective, it was unnerving because it was kind of, the same day, the same time every week. If somebody was going to plot, meeting up with some people for an escape, it was certainly plausible. Fortunately, we never had any issues, but subsequently, it's almost ironic. The pandemic occurred, and that kind of movement became impossible, and some rules have been relaxed with regards to things like methadone. We began the practice of transporting methadone to the jail for the folks that were doing it. Obviously, we began utilizing telehealth for seeing them remotely. But so many things have evolved, and just listening to all the presenters this morning, when we continue to be in a mode of really just continuing people on treatment who arrive on treatment. We so desperately want to expand out into offering it as a way of peeling off another chunk of the population, inviting them into a path to recovery, a path to treatment, so that this cyclic repetition of in and out of jail and in and out of risk of overdose upon release from jail can go away. And so many of the things just have resonated today. We've got some great partners in the Montgomery County Correctional Facility now, and the leadership. We do still struggle, I think, somewhat with getting some of the correctional officers to see the big picture and welcome us there. But slowly but surely, we're chipping away at that culture and hoping that they'll see the bigger picture of, hey, some of these guys, when we start expanding the program, including everyone, you'll see less and less of them. It's not going to be a perfect picture where, the rosy, everybody goes away happy and well, but a certain percentage will stop coming because they will have veered off this cyclic road of misery and onto the, slightly better road of recovery and treatment. And I only say slightly better because it's so much work, and we know that the people that are suffering from this addiction, it's a painstaking one. But thank you to all the presenters today. This has been awesome.
Of course, thank everybody else for allowing us to come to speak and get all the input from other participants as well. And I think the biggest struggle we have is follow-up. When he or she's released, we get the bridge script sent, we get them all set up and squared away. Then we try to reach out to them either on the number of my personal cell phone or the jail phone, and it's either unlisted or they're not answering. I think that's where the biggest struggle that we're having is following up to ensure people are getting into the treatment and picking up the bridge script, et cetera.
Yeah, we got to get you some grant money and some staff to take care of that so that it doesn't fall on your hands. And that's another mention from earlier, where somebody like a a peer specialist can just be gold in terms of being that glue between the facility on the inside and the community based treatment, and make sure those connections happen. But yeah, we got to get you some more funding.
All right, well, thank you guys for allowing us. Thank you. Thank you.
It looks like we have a question from Stephen Murphy. Can you unmute yourself?
Hey, yeah, so I'm with Montgomery County, and I went to tour Fairfax Detention Center about a week ago, and as a part of their for the inmates that are on MAT, they send them, when they're discharged from custody, they get a care package that includes a cell phone. They got some grant funding to be able to do that, and they were saying, of course, you know, a lot of times inmates, once they leave custody, they don't necessarily want to have any contact with the jail. But they said they've seen a lot of success in getting connected from jail to community provider. And so that's one of the things that we're going to try to model. What we're going to steal, as they say. I'm going to steal it from them. It's good. I think, you know, when you think about connecting the inmate prior to transitioning, connecting them to the next level of care, the earlier you do that, the more likely they are to follow up. So those are some of the things that we're working on.
All right.
And
That's awesome.
Stephen, correct me if I'm wrong, but I think you said that they got their money for that from something called a Chris Atwood grant.
Chris Atwood Foundation. Have y'all heard of them?
Mm-mm.
I don't know if it was a Virginia thing or what, but yeah, they have they did the Chris Atwood Foundation is who helped fund that particular thing.
What a great opportunity there. And I know, Rebecca, like your connection rate that you presented in your slides was mind-blowing, like something we would all dream of. What is your special sauce for making such a good connection with folks starting your program to link with providers in the community?
Our nurses do not give up on it. I don't know. I think someone just echoed this. It is the first thing they're talking about. Like, it is number one, the first day you're medicating, anytime you're talking with your counselor, as you're, we're talking about release, it's where are you going? Do you know where you're going? How are you getting there? Do you need help getting, it's so much a part of treatment there, that we're assuring it is literally pounded in their heads before they leave that program. But then again, as soon as they are released, our nurses are on the phone, connecting with them the next day, trying to make sure that they've gotten connected. We're assuring that everything is set up for them. And again, we have access to a lot of different options. We have access to peer support, access to assisting with transportation if we needed to. And one of the things that we're working on right now is we haven't had our first buprenorphine patient yet start, but what is that going to look like when they get released? Because it's going to look very different. Our plan of action is to have a script being sent to a pharmacy that we've established in the community with for care, in which that individual can go pick up medication. But then on the back end, having a plan B with our mobile buprenorphine program to be able to catch them, to provide a script if needed, and then really to be the resource to connect them to care. We have a peer support specialist on that mobile program who is key to assure, she is always on top of assuring that those individuals are connected to care, that they've followed up. So I feel very confident in putting that piece into the role, knowing that she's going to be there. But I think the really biggest thing is that it's one of the first things that we're talking about. So they know it and it's established before they leave. But again, just to put this out there, these are for predominantly individuals that are already established in care. So they want to go back and get medicated. There's not a lot of convincing needing to happen, to put it out.
That's a really important point. Yeah, it's apples and oranges when you're talking about someone who is not yet engaged in care, trying to engage them in care during that detention and then link them with care in the community, because they would have potentially very different reasons for starting.
Yes, backtracking a little bit to Captain Wallace, asking about methadone and switching to buprenorphine. You can definitely do that. By all means, every clinic's going to be different, but here at Allegheny, when we have someone that's on methadone and wanting to make that switch, very first step is getting a hold of the clinic, letting them speak to their counselor there. And then if this is something they want to proceed with, again, it's going to be case by case with the clinic you're working with, but they typically will go down off the methadone about 5 milligrams a day or every other day until they get down to about 30 milligrams. And then they just don't give them anything for about 3 days, and then they can start on the Subutex.
Uh-huh. Thank you.
Thank you.
Yeah, and it's being developed, right? There's a lot that's being worked on right now in terms of that transition process.
Yeah, so it's definitely possible. It's just working with the clinic, but I mean, we've had quite a few people that have asked to do that.
And that's with pregnant females as well.
I'll be honest, I haven't had any pregnant females ask, so I'll let you know if that ever happens to me. But I've only really had one pregnant female on methadone. For the most part, the people that I have coming in that are on drugs and pregnant aren't on anything at all, and we get them started on the Subutex.
Gotcha. Thank you so much.
Mhm.
You're welcome.
It's interesting that the discussion about methadone treatment has turned into how to get them onto buprenorphine because there's obviously some other factors associated with the capacity to treat people with that medication. Larry, I see your hand raised.
Yeah, and I'm not speaking as a medical doctor because I'm not a doctor. And if there's one here, they can pipe up. But yeah, I think that transition probably isn't something that you would do with a pregnant client. The whole basis of treating somebody with MAT during pregnancy is keeping somebody stable and not in withdrawal. And that process actually induces withdrawal to make the transition. So you would be risking health to the unborn by going through that transition. We do lots of transitions from methadone to Suboxone or buprenorphine, and the other way, probably not as frequently, but we do both transitions, but not with folks who are pregnant.
Thank you.
Rebecca, you talked about all of the sort of head start that you get when you, as the county health department, are partnering with a local correctional facility, being under the county, having lots of other, oversight and guidelines that you share, or communication processes and things like that. Are there experiences that you've had that might be helpful to Captain Wallace or other counties where they're not partnering with their local health department, but are, creating new partnerships with local treatment providers in order to provide medications like methadone?
Yeah, I think, and we find this even within the community programs when we're trying to partner with other agencies in the community to really, at the end of the day, the goal is to get everyone connected to care, and that we're doing things working together rather than apart from one another or against one another. And even with the correctional facilities, I think the biggest piece for us is having really clear and established roles that everyone is coming into. So, for example, right now, we're still finalizing processes with expanding access to the Jennifer O Detention Center. We meet on a very regular basis where we have continued conversations about what does flow look like, have really crazy looking flow charts. And they're sometimes frustrating meetings, or we're going back and forth, but they're there for communication purposes and to really look at what are things going to look like and realistically, and it's having all of the players on board, from administration to the nurse that's going to be medicating. What does that look like? What are concerns that might come up? So workflow charts are great. Really established protocols are extremely helpful, that are in partnership with one another. And then, like I said, I think that some type of MOU or understanding of really established roles. I think it helps not put agencies against one another. When you can come back to, this is what we talked about, this what's working and what's not. And then regular check-ins. And I think not a regular check-in where it says, okay, well, we'll touch base again. And if you like, we're meeting every 2 weeks, Tuesday at 11 o'clock, whatever it is, because then that is set there. And I know that sounds really small, but I think it's really significant because it keeps the conversation happening. I know when we didn't have that, just in the last year when we've been working on this process, things just kind of fell to the wayside and other things came up. And now it's on my schedule. It's every week now, every week. And I know I have to make sure I'm following up on things and getting on things. And I think it's been really significant in us building this program, is putting, reaching out and making sure that we're listening and establishing really clear roles with one another. And then I think from an education standpoint, from like a treatment provider, I think being able to provide really support and open forum where you're not coming at it from defense mode, because I'm always going to be a supporter of treatment, but I'm one piece in this big puzzle, and there's a lot of other players. So trying to understand and look at it from that realm.
Those are great points. Something that you said jogged a study we were involved with, an MOUD implementation study years ago, and the implementation process involved regular meetings by jail, community treatment, parole and probation, and all of bringing them regularly to talk through what that might look like. But one of the things that when I was doing qualitative interviews with the committee members was how much just visiting the facility, like from a community treatment standpoint, like going to the Kent County Jail, seeing what it's like, seeing how people are held, and understanding space limitations and staffing limitations, like it was helpful both kind of for breaking down misconceptions about what it looks like. We're all here together, we're trying to work for the betterment of these people, but it also generated new conversations about ways to enhance that relationship. And I don't know, Captain Wallace, have you had community treatment providers come to your facility to work with you about that? I know you are the bridge. You are wearing so many hats where you are, and if expanding access, whether it's methadone or, of course, the buprenorphine program that Dr. Weintraub is working with you on, or Dr. Fishman for the counseling, that's remote and not on site, and there can be sort of a different chemistry that happens when people are there and talk through things with you.
At this time, we haven't had nobody come to the facility and try to help us with this struggle. I know the Witches Center has a mobile van, but I don't think they do methadone. I think it's just Suboxone. But I'd like to emphasize that although methadone treatment oftentimes is a struggle for a lot of agencies for a variety of reasons, we still remain focused on how important this treatment is to he or she. So we never lose focus of that, regardless of the struggles. I just want to emphasize that. We're here, we're going to help people as we all do. Sometimes there's barriers. We did get a grant for the MAP program, which is a blessing. And I think we're going to look into the cell phone thing, like he mentioned, upon release. I just don't know if, I'm assuming it's a prepaid cell phone, and when the minutes are up, they would have to recharge it. But in any event, it's better than what we have now, because the system we have now is not working. The peer recovery specialists in our area, unfortunately, one just left, so now we have two, which makes it difficult. But we continue going, and like I said, with all the help of other agencies, Friends Research and University of Maryland, and reaching out to others that are going through similar stuff, it's a big help, and we really appreciate it.
Looks like Stephen Murphy confirmed, yeah, they're prepaid cell phones.
Awesome.
So that's good. And if anyone would like to connect with Captain Wallace, I was the one sending out the registration emails. You can contact me and I can connect you all. Or if you want to put it in the chat, we'll save that and we can forward that on.
And if anybody knows of a MAT manager, we're desperately looking for one. I know this is not the platform for that. And that would be a big help because it can be overwhelming. I don't know how big agencies do it with 40 or 50 people in the MAT program. When we have 10, you know, it's especially when you have a nurse, you know, 5 or 6 nurses within the last 8 or 9 months that for a variety of reasons, it creates, you don't have no stability and it makes it really difficult. But we got a great team and we're doing it. So, but thanks again for having us.
Oh, thank you. Yeah, no, you've really knit together community resources from what's available either locally or through the state, because, you know, you've really made the most of the telehealth opportunities to expand care that might not be present right there in Kent County or be on site, but that can be delivered to meet the needs of the people in your facility. That's really commendable.
Thank you. And so far it's working. Everybody's extremely happy. All parties involved. So the patients seem to be doing well. They're very receptive to everything, the medication and the treatment, counseling. So we're happy. All the data is being collected and sent to the grant manager. So we got a great team here. So it's working. It truly is working.